Okay, good afternoon, good morning, or whatever time it is, and welcome to our presentation on melanoma and the treatment of binimetinib. For an interest of just pronunciation, we'll go with the binimetinib. It will be called BNIB or Mektovi. So the team presenting is team one. I'm Gennaro Coppola. Also, the team had Sarah, Anthony, and Elizabeth. And Sarah will be speaking for Elizabeth due to kind of like technical limitations or technical problems. Okay, so we based this presentation off of two articles. The first was a review of BNIB for the treatment of mutant cutaneous melanoma, and the second was just a continuation of one of the trials mentioned in the first article, which was the Columbus trials, and that's it. So the next section will be Sarah's turn to talk.
Hi. So melanoma is the worst type of skin cancer to have, and it really begins in the melanocytes, which are cells that reside in the skin and the eyes, and they produce pigmentation. So I have a picture of this kind of on the bottom right-hand corner, and the melanocyte is highlighted in blue. So melanoma is a malignant melanocyte, and it's in the epithelial tissue, which is between the layer of basal cells. Melanoma can be recognized by ABCDE, which is commonly taught. And it's just kind of when you look at your skin, at the bump on your skin, and it's asymmetry, border, color, diameter, and evolving. And the biological subtypes of melanoma, which I have listed, are cutaneous melanoma, which we're going to be focusing on, acral melanoma, which is in the skin and the hair follicles, specifically soles and nail beds, mucosal melanoma, which is in the mucosal lining of the internal tissues, and uveal melanoma, which is in the eye. So it is important to note that BNIB does treat malignant melanoma that is not typically able to be removed by surgery. And I have another picture in the upper right-hand corner, which might be a little bit hard to see, but it's just showing the melanoma, or the melanoma just going deep into the skin. So in melanoma, the loss of function mutations are due to mutations in NF1, which is seen, again, it might be a little bit hard to see in this top right-hand corner, but this NF1 little red box, NF1 typically inhibits NRAS, which would allow for regulation of the signal transduction pathway. And the loss of function mutations in tumor suppressor genes allow for proliferated survival and life of the cells at an uncontrolled rate. And in this case, NRAS over signals BRAF, which is a mitogen activated protein kinase. And this really hugely does amplify the signal. The key hallmarks are evasion of growth suppression as the NF1 tumor suppressor is inactivated, and an activating invasion and metastasis, which is the cancer just continuing to grow in the person's body. And I have another diagram on the bottom right-hand corner. It's a little bit oversimplified, but it's just another good way to visualize what's going on.
All right, so melanoma is caused by gene mutation in the BRAF gene, predominantly the V600E hotspot mutation, which occurs in 40 to 50% of all melanoma. This mutation has an effect on the loss of function mutation in the tumor suppressor gene NF1 that can be infrequently be detected in BRAF. The BRAF protein is a signaling molecule in the MAPK protein, which is a signaling pathway for the cell growth. The BRAF is a proto-oncogene that becomes oncogene when mutated. This results in a continuous production of proteins, in which turn results in a tumor. To help with the stopping of this mutation, patients were given BNIB, which blocks the action of the mutated BRAF gene and stops the signaling cancer cells and not allowing them to multiply. BNIB does this by blocking the signals to the V600E or the V600K mutated BRAF molecule through the MEK molecule. Individuals who have the BRAF mutated gene with malaria are typically younger in age. And for melanoma, 93.7% of individuals survive for more than 5 years after being diagnosed. The rate of new cases was 21.5 individuals per 1,000 men and women per year. The death rate was only 2.2 per 1,000 men and women per year. The rates were age adjusted and then was taken from a 2015 to 2019 cases and deaths. They claim that 2.1% of individuals will be diagnosed with melanoma in their lifetime. Individuals who get diagnosed with melanoma most frequently are non-Hispanic whites, with an age-adjusted study in 2015 to 2019 per 100,000 people, with men being 38.6% and women being 25.5%. With non-Hispanic Black males make up 1% and non-Hispanic Black females make up 0.9%. With non-Hispanic Asian males, they make up 1.4%, and women of the non-Hispanic Asian make up 1.2%. And then Hispanic males make up 4.6%, and Hispanic females make up 4.5%. From the information, you can see the males are more prone to melanoma than women, and non-Hispanic whites are more prone than other ethnicities. From the same study, they looked at aged individuals in the age group 65 to 74, and they showed that 25.8% of being diagnosed, with 55 to 64 having 22.4%, and 75 to 84 having 18%, showing that the older individuals are more prone to being diagnosed with melanoma.
Okay, so it has been shown that about half of the metastatic melanoma cases have patients that, it has been shown that the metastatic melanoma cases have cases that do progress to people that pass away. So in cases where patients have NRAS mutated melanoma, they do not have a plethora of treatment options, especially if it cannot be removed by surgery. So in NRAS melanoma, BNIB is the first targeted therapy to have shown some true clinical differences in the inhibition of melanoma. And BNIB was proven in a phase 3 trial to be the first targeted therapy to have an impact on the progression-free survival of melanoma. And another thing to be included is the age and location of primary diseases tumor can be traced to the 4 mutational subgroups, while mutation-specific targeted therapy has only been established in BRAF mutated melanoma cases. So in this phase 2 trial, there was a group of 10 different males with 10 different cancer types. They were all given varying doses of BNIB from 30 to 80 milligrams twice a day. And all these men did progress heterogeneous mutation profiles. So it was shown that the dose-limiting toxicity happened in 2 out of the 4 patients that did take the 80 milligram dosage. And they experienced these rashes and the central serous-like retinopathy, which is both in the bottom of the slide and with the eye, it was just a lot of fluid in the back of the eyes. And it's important to note that these side effects did resolve when there was a decrease in the dosage that was given, which was good in these patients' cases. So other side effects, it was shown that with BNIB, there's just moderate side effects, so the rash and the liquid behind the eyes, but again, they did go down after the dosage was lowered. There was also a couple more serious side effects, so hypertension and residual swelling, but a lot of these are really typical side effects in other MEK inhibitor drugs. This side. So this is just a graph that Elizabeth included to kind of show the efficacy of the trial and things that had happened. And the current standard of care is BNIB combined with encorafenib, which is another kinase inhibitor. And the current dosage of BNIB is 15 milligrams, where the encorafenib is 75 milligrams. And there's been proven to be minimal side effects, which is incredibly favorable for the patient and for the treatment of this disease.
I forgot to turn on my microphone. So like was touched on earlier, there are several types of mutations in cutaneous melanoma. among them being the BRAF mutant melanoma, NRAS mutant, and NF1 mutant. Especially for the BRAF mutant, the most common is the V600E mutation, and that's what our papers covered. So the BRAF melanoma is one of the most common types, with 40 to 50% of the cancers expressing this mutation.
He is not going. There we go. I'm sorry.
Okay, so as goes for prognosis, usually if you have stage 0, stage 1, you have about a 93.7 chance of surviving over 5 years for in situ, or with the overall mortality rate being about 2.7. So the odds of dying from this condition is relatively low. However, if it progresses, it changes drastically. And I have a graph on the next slide to better illustrate this. Or maybe not on the next one, my bad. So the propensity to spread, so usually in situ melanoma does not spread. It's localized in one area. It's not as invasive, or except for local area, and is usually easier to treat. But metastatic or invasive melanoma, which our paper focused on, it can spread quite quickly and is fatal, and usually spreads to the lymph nodes and other areas, and that's what causes the problems. And usually metastatic or invasive melanoma will increase your risk of death and decreases your 5-year survivability. So here's the 5-year survival. So the localized, you have a 99.5% chance of surviving. However, as it starts to become metastatic or invasive, that survival starts to decrease. So from 99, it goes to 70, then to 31. So if you're looking at distant metastatic melanoma, your odds of dying for it, your odds of 5-year survival are relatively low. However, we can treat to a certain extent. Okay, so before we can choose what kind of treatment, or a physician can choose what kind of treatment to give a patient, they assess the melanoma via a T&M system. So T stands for the tumor or other factors associated with, such as its thickness and ulceration. The N stands for whether or not the cancer has reached the lymph nodes, and M is for if the cancer cells has reached lymph nodes or other organs. Like N is if it's in transit as well. So if it's not present but has the potential to go there. So once those have been assessed, you can start talking about different. They can determine what stage it's at, and then they can determine treatment options. Okay, so for the different stages, early stage melanoma, stage 0 is that it's like the in situ type of melanoma. It's really kind of just small, and it's not that dangerous. Stage 1, it's a little bit larger and may or not be ulcerated. And intermediate or high risk melanoma, which is stage 2, the melanoma the cancer is a little bit larger. And at this point, there's a chance that could start to become metastatic. And then advanced melanomas are at stage 3 and 4, and that's where BNIB plays a role in treatment. Okay, so at stage 3, usually the melanoma is invasive and spread to the lymph nodes or 2 centimeters from a primary vessel of a lymph node. Usually you can tell this is the case if the lymph nodes are enlarged, but that doesn't always suggest that it's there. Then there's stage 4, where to determine how bad it is, they check the concentration of serum lactate dehydrogenase. And the higher the LDH in the blood, the more damage has occurred. Okay. So for treatment options, you have surgery only. This works well for in situ or early stage melanoma. Then you have surgery and radiation. Again, it works well on early stage and intermediate or high risk melanomas, and then drug therapies like BNIB. And this works best at stage 3 and above. Okay. So as for drug therapies, patients have a few options. There's immunotherapy such as anti-PD-1 treatments, such as Opdivo and Keytruda, and they act as inhibitors for the PD-1 molecule. Then you have targeted therapies. So you have BRAF inhibitors such as Zelboraf, Tafitinlar, and Bractovi. And then you have combination therapies such as the MEK inhibitors with BRAF inhibitors such as Mektovi. Okay, so overall patient experience with Mektovi, there is a severe reduction in metastatic melanoma. However, side effects included, nausea, diarrhea, vomiting. However, nothing too terrible that would affect the patient in terms of like immune response. Okay, and this is just a segment we compared the Mektovi with other MEK inhibitors that were being tested, and it showed that Mektovi is still proven to be the best standard of care compared to other MEK inhibitors. Okay, so some patients also experience a survival rate of about 33.6 months, a decrease of death by 29% compared to the VEM treatment, and progression-free survival for about 14.9 months. So overall, patients had more benefits than side effects, showing Mektovi is the way to go to treat BRAF V600 mutant melanomas. Okay. As for resistances, usually higher stage melanomas usually develop some sort of resistance in the form of acquired resistance. So usually if a melanoma is treated with a BRAF inhibitor, within within 4 to 6 months, they will develop a resistance because they find another way to turn on the MEK kinase. However, oh shoot, 17 minutes. Do I need to continue? Okay, wonderful. So yeah, I guess next slide. As for the design ideology behind Mektovi, so they found that a combination treatment with BRAF and MEK prevented the resistance from occurring and also helped reduce the tumor load. Okay. And again, like what I mentioned before, a selective inhibitor such as Mektovi would, in addition to BRAF, reduces the amount of cancer cells and is successful to a point has become the standard of care. Okay, and that's just a quick graphic showing how Mektovi targets the MEK pathway. Okay, so some off-target effects that were touched on before, is like rash, acne, fever, dermatitis, diarrhea, fatigue. And this could be due to increased amounts of creatine phosphokinase, and also suggests that the therapeutic index is relatively large since there's no really debilitating side effects. Okay, that's it.